Good morning. My name is Natale. I am a pediatric psychologist and the co-director of the Community Health Interprofessional Collaborative. How many of you are familiar with the IPCs, as we call them? Most of you? Okay, great. So this is our first grand rounds from the Community Health IPC, highlighting a feature program that really embodies the spirit of what we're trying to capture through our IPC, which is partnering parks and physicians to reduce health disparities and inequity in childhood obesity. So since this is our first grand rounds, I thought I would just start by briefly going over the mission and the logic model of our IPC. And then Eric Hansen from Miami-Dade County Parks, Recreation Planning and Program Development, will talk about some of their obesity prevention programs, in particular Fit to Play and the Parks Prescription for Health. Then Dr. Sarah Mazaya, who is the co-lead in our IPC, will talk about the Community Epidemic Collaborative and some of the outcomes of this, as well as some means for expansion. And then Dr. Lourdes Forster will end with the importance of moving pediatric medicine into the community. So as you all know, the vision of the Mailman Center is improving lives through innovation, impact, and connection. And our Community Health IPC aims to uphold this vision through our mission statement, which is to reduce health disparities at the intersection of developmental disabilities and minority status through innovative community-based approaches. And we intend to do that in 4 ways. First, we will use research. We will use dissemination and implementation science to translate research into evidence-based practice. We will expand clinical services by coordinating with community-based programs. We will promote advocacy for the underserved through our multidisciplinary network. And we will increase opportunities for training, community-based providers, and medical professionals. So who comprises our Community Health IPC? Many of you are here in the room today. It's a very vast array of members from multiple disciplines, so we're truly interprofessional. We have pediatricians, early childhood educators, psychologists, occupational therapists, social workers. We've been meeting since July of last year, and we've been working really hard to develop this logic model. And I apologize, I know it's very busy. It's something that we typically use for grant applications, but it really does summarize the spirit of where we're trying to go in over the next course of the few years. So we started in July with a needs assessment that all of our members completed and came up with the current situation of the community and some things that we wanted to target. And I know it's hard to read, so and things highlighted are the programs that PARC specifically relates to. So there's needs for programs that start at birth and that go through the developmental trajectory. There's needs for interventions with high-risk populations. There's needs to provide services in naturalistic environments. Some of the activities that we're hoping to accomplish, again, our focus is research, training, clinical, and advocacy. But some of our research activities that the members decided would be beneficial would be to develop evidence-based programs consistent with team science and to develop novel obesity prevention strategies. Also related to advocacy and community engagement, we thought it's really important to incorporate community agencies to improve impact. So we want to establish more academic community partnerships, which Dr. Mazaya will be talking about. Some of our initial outcomes are to identify community agencies that meet our mission and to build on or develop new programs that fit these current needs, which the Parks Partnership does perfectly. Our intermediate outcomes are to identify sources of funding and ways to enhance collaborative dissemination and implementation research. And ultimately, because this is an academic institution, we want to make sure whatever programs we develop are evidence-based. And then our long-term outcome, of course, is to increase the collaborative strength of MCCD and the community on health outcomes for children, which you'll hear in just a minute, the wonderful outcomes that Parks has had on the cardiovascular health of the children in the community on BMI outcomes, blood pressure, and things like that. And they've done a wonderful job as well of improving access and reach, and also in developing an innovative and really sustainable program. So all of this leads to our ultimate mission, which is to reduce health disparities in the community. So now Eric will talk more about the details of the Parks program.
Good. Okay. Well, good morning. I recognize some faces from a previous meeting. Very happy to be here this morning and to talk a little bit about the work that we've been doing for the last couple of years in partnership with the University of Miami. We did this presentation at the Florida Recreational Park Association meeting a couple of months ago up in Broward, and last night I decided I was going to change my slides. So this is a dry run of new slides, and so have a little patience with me. Before I start, let me just tell you a little bit about my work with the department, what my responsibilities are. So I'm the manager of recreation planning and program development. So my job is to develop the programs that happen in our parks. And it's our population, our target population generally are kids 6 to 14 years old and older adults, 55 and older. And that's generally the folks that come to our parks for a lot of reasons, but those are generally the folks that I create programs for. When you think of parks, you generally think of things like this. You know, you think of a park, somebody who works in a park, you think this is what they do. They work in this great environment every day, and they look out the window and they see this. They you know, during 10 o'clock they might meet in outside like this, or we might have lunch you know, someplace like this. I mean, we have some really, really great venues and scenes, and you know, a lot of people think of parks in this manner, and I just added some things in here, thinking about doing this. This is not me or walking through here, paddling, socializing with friends at a park, doing classes. This is actually a class at one of our parks. Working out in some of our outdoor exercise areas, bicycling, kids and running and jumping and playing around. And that's what most people think about parks. But you don't think about us in this table, at this table, and having conversations with folks like you. Not until recently. You don't think about us sitting at the table with transportation and talking about how we might be able to solve some of the traffic, although I think that ship has sailed. I get in trouble all the time for speaking my mind. But you know, we sit at the table and talk about solutions to bigger problems than what you saw earlier, where I'm going to eat my lunch that afternoon, or what park I'm going to take a walk in. We're at the table and talking about how we can reduce traffic by providing alternative solutions to getting to work, right? Riding your bicycle, providing that bike path on our roads that you don't see in this community, but you see in other communities. Talking about how we have sprawled and bringing folks back in and talking to housing and developers about building multi-function and multi-use neighborhoods where a park is in that neighborhood and you don't have to get in your car and drive to one. We're at the table with developers. I've lost my place and notes here. We're at the table talking about issues that you see every day in clinic. We're talking about social and behavior and emotional and physical conditions. We're at the table and we're talking to the different folks. We're at the table with police and juvenile services, talking about how we can help to reduce the violence that's happening in our neighborhoods. 20 years ago, we were not at the table for any of those conversations. We are at the table now because we can play a very important role. So, 6, 7 years ago, 8 years ago, childhood obesity was the hot topic. Today, I think, while childhood obesity continues to be a hot topic, the violence that's happening in our neighborhoods is really the buzz that's going around right now. But I don't think anybody solved this problem yet. We're working toward it. But 8 years ago, this was the buzz around town and around the nation. And so we thought about how can our programs help impact the childhood obesity epidemic that was sweeping across our country. And we were very fortunate to, and these are just some things, sort of stats, and I don't need to tell you about all of this stuff. But we were very fortunate to have this. It sort of was a perfect storm. I was coming into this new position, and my first job was to look at our after-school program and figure out a different way of doing things. And it was at the same time we began to have conversations with UM and Sarah, and we said, let's look at revamping the whole after-school program. We had 35 or 40 after-school program sites at that time, and each one of them did their own thing in the afternoon. And it was very, very ineffective, and so we said, let's look at putting together an after-school program that was consistent and actually a curriculum that meant something and that we could test. And Sarah is going to talk about that in a little bit. I don't want to steal her thunder, but I wanted to sort of, make the connection, where we started and why we started. So 6 years ago, we put together a working group. We determined the methodology of program delivery. We identified the core components that we thought was important. Spark is an activity that keeps kids active for 45 minutes every day. And that's really the core of this program, is keeping kids active for 45 minutes. They spend a lot of time sitting at a desk in school, and so when we get them into the parks, we want to make sure that they get that 1 hour or, more or less 1 hour of physical activity each and every day. We added nutrition education, rep games, life sports. We thought it was important that they learn golf and tennis, the basics, because those are sports that they can play over a lifetime as they grow older, if they're introduced properly as kids. And I could go on and on about that. And then a little bit about homework help, because parents want kids to do their homework before they get home. I think parents are more lazy sometimes than the kids, and they don't want to be bothered with homework. So as soon as they can get that homework done, and we provide that little bit of time at our after-school program to get that work done. But the majority of our time is spent in physical activity. So, we consider this program sort of a solution to the childhood obesity epidemic that's going on and continues to go on. And that sort of morphed into the idea over time as we as we continued to deliver the program, and we developed a team that went out and did measures, and we collected the data, and Sarah did the analysis on the data. It was logical then, 2 years ago, that the prescription thing started going around the country, and doctors were prescribing folks to go out and to parks or go out and exercise. And so this sort of was going around the country, and so we figured, how can we now move or take advantage of this prescription and move doctors to prescribe kids to go to this program. It's an evidence-based program, and I'm stealing some of their stuff, but so this was sort of the next process in our evolution, in our partnership evolution. So we looked around at what other folks were doing around the country, and I mentioned it a second ago, in that in most cases doctors would just prescribe patients to go to a park and walk, and to go to a park and exercise, or go walk or jog or ride a bike, and that was it. And so we thought it needed to be a little bit more than that. It needed to be something more tangible that we could be able to revisit, and it would go around and close the circle. So we looked at everything, and National Parks has a prescription program, and Sarah and I listen. We are on a national prescription coalition that we monthly phone calls from around the country, and Lourdes will tell you a little later on that we're sort of the national model for prescription, because we do it a little bit more unique than anyone else does it. So we created an office that we have health and wellness specialists that are trained to train our park staff in program delivery. They do all the data, the biometric testing, and Sarah will talk a little bit about that. There are 6 staff that are in there. Some of them are masters of public health from this school, and we've hired them to be full-time park employees. That doesn't happen very often in a parks department, that we have master level public health folks that are full-time employees. So we're very proud of that, and I think that's me. So I'll get out of Sarah's way.
Yes. Okay, so I also know a lot of you in the room, but a lot of you don't know me, and I don't know you also. So my entire career, I have focused on childhood obesity, both prevention and treatment. And it's interesting that at this very same time, I was having conversations with Eric about solutions in the community for obesity. I was also having daily conversations with our clinical teams, pediatricians in the general peds clinic, GI, endocrinology, basically all of them would call me constantly and say, Sarah, I've got 1 out of every 2 patients coming into me that are overweight, really struggling with healthy weight. Where can I send them in the community? And at that time, I was very hesitant, because as an epidemiologist and a medical scientist, it's easy to send to a program. It's a very different model to send to an evidence-based program. And so I really wanted to be on the ground floor of developing a program like that, so that we could refer our patients, and in turn our physicians would feel comfortable in putting their reputation on the line when they did make these referrals. So again, Eric alluded, it was a perfect storm. Well, for me, it was a really great storm, because I was able, as a medical scientist, to merge my passion for community health with my specialty in obesity prevention and treatment. So as Eric alluded to, our program that we developed, starting, it was almost 8 years ago, is called Fit to Flay, and it is a park-based program. And when they came to us, they said, we really, we want to be more than a babysitting service, because so many of the programs that are offered, especially in our county schools right now for after-school programming, is basically just parking the kids in another classroom after school until the parents pick up. So I'm sure a lot of you in this room who work with schools too know the challenges of trying to work in the school system itself. Their day is already overburdened. The teachers will tell you that there's not one more thing that they could squeeze in during the day. Meanwhile, the after-school space, it was very enticing, because those 3-4 hours after school are when you can really capture children. They're coming out of school, they're ready to burn off some energy, and a lot of them go home and they binge. They eat and they sit on the couch. So it was a great time to sort of turn that whole model around. So as a team, again, this is a very, very collaborative approach that we took here. We made decisions on how we were going to design this program, and that a lot of that was driven by the realities of what can happen in a community-based setting. There's lots of ways I can measure obesity changes, body composition changes, clinical cardiometabolic changes here in clinic, right? But there's a lot of things that we do here that are unrealistic, that cannot happen in the community. It's unrealistic, for example, to think that park coaches can draw blood, or that they can do very complicated body composition measures and so on. So we did a lot of talking and walking through the design phase of this before we even hit the go button. And this is to this day too. I mean, to this day, every day, I talk to parks multiple times a day on everything from design all the way through to data collection, interpretation, and so on. And as Eric mentioned, sort of the spirit of this morning is we've really turned a major corner in the past 18 months or so, where now we are an evidence-based program that is being prescribed by our UHealth pediatricians, and we're really excited about that. It's the first program like it in the nation. We're actually going on a national, international webinar next week highlighting the program, because we presented our preliminary results in Vegas at that national conference last fall, and it was standing room only, and it was so well received that the National Association asked us if we could do a follow-up in the webinar format so that more people could watch it. So we're really excited about that. But what got us there is the evidence. And as Ruby said, again, being an academic institution, that is our mission. Any program that we develop has to have evidence behind it. So when the pediatricians were coming to me and saying, where do I send my patients, I would say, just wait. Can you wait a few more years, because we're developing a program, but I need to know it works first. I can't be having you just sending patients to a program because it's a program. I really want to know that it works, it's going to benefit our patients, it's going to improve their health, and it's going to improve those patients that need the help the most, our neediest, and the ones that are lowest resource. So just thinking very broadly, working with community-based organizations, coming to the table together, these are some of the questions that we talk about all the time. And we agree and we disagree, and we all eventually come to a middle ground. Who do you want to reach? In this case, we still, to this day, have one, and Lourdes will tell you, 1 out of every 2 of our ethnic minority patients that come to the general peds clinics are struggling with healthy weight. 1 out of every 2. So it's still a major, major problem in this community and in the nation. Who can you partner with? This was also, again, as somebody is very passionate about community health, it's very easy to see, we're failing at combating the childhood obesity epidemic, and that's not the fault of pediatricians or clinicians. They only have a very few minutes with the patients that they see them face to face. It's impossible to do the daily program. Where the rubber hits the road, it's every day in the community. How active those kids are getting, Are they getting exposed to nutrition education? Is the family learning about healthy eating habits? Are they being active together as a family, and so on? So what community-based organizations can you work with to get those missions accomplished? It was a natural fit with parks, obviously. What do you want to measure? I've already, I'll discuss that in the next set of slides. What we ultimately decided and agreed upon were the measures that we could implement in a community setting and get outcomes that were meaningful and showed us that the program actually was working. And what would you like your ideal outcomes to be? In our case, for sure, it was actually twofold, because we ended up being not only a prevention model, but also a treatment model, because now we are getting referred patients that are already overweight and obese, but at the same time, we're a prevention program, we're a community-based program, so the biggest story about the childhood obesity epidemic that constantly is never spoken about is we still have half of the nation that's normal weight. And it's just important to keep those kids in that normal weight category for as long as possible and keep their healthy weight trajectory going in the right direction, while simultaneously having those kids that are already up there coming down. So I'm sure this is no surprise to anybody in the room. Obviously, we have a major, still, obesity epidemic in Miami. Yes, violence is definitely taking the stage right now. But we're also thinking about, as we're designing programs for at-risk youth, how physical health can help actually combat that with the stresses and everything that they're going through in their daily lives. As I mentioned, nearly 1 in every 3 children we see in our pediatrics clinics here at UHealth are overweight or obese. We have a lot of disparity in our community here, and no surprise to anyone again that those kids coming from the lowest socioeconomic backgrounds are affected the most by unhealthy weight. And certainly, also I'm sure it's no surprise, the health-related consequences also very, very high, namely diabetes and cardiovascular disease in our non-Hispanic, Black, and Hispanic populations, locally and nationally. So why is this? We're a sedentary nation. Bottom line, our kids don't really move anymore. They don't even go outside anymore, which is sort of like the third dimension of this entire program that I find fascinating, is what is the benefit of being active outdoors versus indoors? And I struggle with that every day, how to measure it, and I'm gonna figure out a way, because I feel like it's really an important piece of this whole picture that we're giving you today. 96% of elementary schools in the United States do not offer physical education anymore. And obviously screen time, it's not just TV anymore, right? It's actually not TV at all. It's phones, it's tablets, it's everything else. But kids have their face in a screen all the time. So they're not moving, and they are not learning really about how to eat right and have quality nutrition intake at the same time. So when we were developing the program, we realized to combat the obesity epidemic, it's multifaceted, which is part of the challenge, right? I mean, it's not just one thing that you have to target in terms of behavior, it's a few. Absolutely physical activity, just getting kids active, consistently active every single day, moving all the time, was what we really wanted to set out to do. So and again, we didn't want to reinvent the wheel. There were lots of evidence-based curriculums that have been implemented in school systems around the nation. So we partnered with a group in San Diego who was funded back in the early 90s by NHLBI to develop a program called SPARK, which stands for Sports, Play, and Active Recreation for Kids. And this is the core curriculum that Miami-Dade County Public Schools uses in their PE program. So we wanted to be parallel with that program too. It's evidence-based, very, very heavily published on the effectiveness. It's a binder now, I think it's almost 800 activities, but it's super thick, and it's play-based. I mean, that's another sort of key message here. is we absolutely did not want this program to be like a militant boot campy style of physical activity, because we wanted children to learn to love to be active. I don't know any kids from when they're little who don't, when you put them on the ground, just don't take off running. And it's their nature to be active. So we wanted to support that, instill it, and keep it going. It's not competitive sports. Our kids are ages 6 to 14. Mean age is 9 years old, so they're still young. And they're learning about how important it is to be active, and hopefully we're instilling in them that it feels good to be active every single day. We sent our park coaches to a training to learn the entire curriculum. The great thing about Spark is that they provide support nonstop. So we have a really great relationship with that team, and anytime we need support for team training, materials, they're there for us. Then the second piece, of course, is the nutrition education curriculum and component. And again, we didn't want to reinvent the wheel. There's lots out there, and we decided ultimately to go with a curriculum called Empower Me for Life, which was created by the Alliance for a Healthier Generation, and it's the American Heart Association Heart Healthy Messages. There's 8 that are the core messages of this curriculum, that go from everything talking about how important it is to be active, to drinking water versus soda or juice, eating fruits and vegetables every day, as well as sleep, how important sleep is, and to get away from the screen. And interestingly enough, over the years, the kids really love this, and we, because we have such a wide age range, 6 to 14, I've had some of my students over the years help me grow that program out into 2 modules. One that is for younger children, 6 to 9, and then our 10 to 14-year-olds, so they get the same core messaging, but more detailed materials as they get older. And then again, we're thinking about the team approach here. How are we going to move the measurements out into the field? And this was a train-the-trainer approach. We have, I just did a training last week with our whole park health and wellness staff, where we go. I have a physical therapist colleague that also goes with me, and we train the entire team on anthropometric measures, including height, weight, waist and hip circumference, skin fold measures with calipers, blood pressure and pulse. We implement the presidential fitness test to look at our fitness outcomes, and a knowledge test to gauge if the children are learning about nutrition in the curriculum that I just showed you. The data is then entered in the field, and we house it here at UM on our servers, and it's backed up every single day, looked at constantly, and then ultimately my team ends up analyzing that data, and then we publish and present the findings together as a joint park university team. So the next set of slides, I'm just going to walk you through the results of 5 years, our first 5 years worth of data. We are in year 6 now. We are going to be going out in April to do post-year 6 measures. So this data, I'm going to show you in the next set of slides, is from our first 5 years. This is on a total of just under 1,200 kids that had a complete data set, a pre and a post for every single measure. We have a lot more kids in the database that have incomplete data. So, but because I wanted exact, perfect data for this first 5 years, I only went with our kids that we had every single measure on pre and every single measure on post. So as I mentioned, the mean age is about 9 years old. We do have kids as young as 1st grade up to 8th grade. What ends up happening is we get a lot through 5th grade. Middle school changes things. They're in school later. They're offered constructed sports activities and other things after school. So they start dropping off a little bit in middle school. You can see we have about half boys, half girls. And about half of our population is Hispanic and about half is non-Hispanic Black. So obviously very high ethnic minority population, representative of Miami-Dade County. So as I mentioned, I mean, I think body mass index it has its limitations, but it is a measure that can be implemented out in the field, and it's a good way to gauge how our kids are doing weight-wise throughout the program. But one caveat is this slide you'll see, this is 1, 2, 3, 4, 5 represent the years, 1, 2, 3, 4, 5, so look at that as a time continuum. The blue bars are normal weight kids, and the orange bars are overweight and obese kids. And as the consistent sort of punchline message from this slide is that over every single year our overweight and obese kids, and this is statistically significant, are losing weight. They're losing, their body mass index is being reduced, their percentile and their Z-score. Our normal weight kids are staying normal. You'll see their bars jump around a lot because of, what do you think, right? Puberty. A lot of them are, like, they come in and they end up leaving us a foot taller and so on. This is actually my favorite slide, this one and the next one, because while weight is important, it does fluctuate a lot during puberty. But what floors me is how many kids come into the program pre-hypertensive and hypertensive that are even normal weight. So to have an effect like this is huge. I mean, I can't even tell you, when I first got this data our first year, and I saw 6, 7, and 8-year-olds that were hypertensive, I had to rerun that analysis over and over and just see it, because I couldn't, it took so much time to process it in my brain that we had kids that were this heart unhealthy, this young. But as you can see, through the program, we are able to, with both weight groups, to, again, statistically significantly lower their blood pressure over the school year. This slide represents just those kids that have hypertension, not even pre-hypertension, hypertension, coming into the program at the beginning of the school year, and how we are able to lower that into normal ranges, or at least even pre-hypertension for our kids that are very high throughout the school year. And this is a mirror of the previous 2 slides. The fitness, that's just getting a kid moving off the couch is the best thing you can do for them in terms of cardiovascular health. And so the Presidential Fitness Test, it assesses cardiovascular fitness, strength, and flexibility. So the chart on the left is the PACER score, and I don't know if people know what that is. It's the test, they call it the beep test sometimes, where you have to run to another, like a cone, and you have to go faster and faster, and the time gets shorter and shorter. So you want to see them increasing over time, the number of what we call laps that they make back and forth. And we're able to do that with both our normal weight and our overweight kids throughout the school year. And then the chart on the right is their run time. We do a 400-meter run too for cardiovascular fitness. And we've been able to significantly decrease their times for both weight groups there as well. Strength and flexibility, chart on the left is the number of sit-ups. Sit and reach is the only flexibility is the only measure where we don't get significant results. And so we're talking about how potentially to increase our participants' flexibility in the program. Change in knowledge scores. Again, we don't look at weight group here, but throughout the whole 5 years we've had significant changes in terms of they just increase what they learn about how to take care of themselves and to hopefully get them on that healthy weight trajectory. So in conclusion, we're definitely, I mean, the thing that's really exciting, it's hard to get an effect on weight for any obesity treatment program for kids when that program is taken away. So, and it's hard in a hospital-based or clinic-based setting, so you can imagine how much more challenging it is out in the community. And the fact that we've been able to do it consistently every year for 5 years is really exciting. I'm working on the publication. We've published a couple of the earlier year findings, but now this is sort of our big paper coming out. And again, you know, lowering the blood pressure is huge. While improving fitness and knowledge, I didn't present today, but we have 6 parks that exclusively service our participants with disabilities. We published findings on them too. They also equally benefit from this program, and we are very passionate about them being exposed and being participants in this program as well. So as I mentioned, we have presented these findings now all over the country. We published in the literature. We even got the attention of the White House, and Michelle Obama came in here the year before last and actually endorsed the program because she was making an announcement that the Let's Move campaign was going to be partnering with parks because she saw the benefit of parks as a community resource to combat the obesity epidemic. So it was sort of like a pillar moment for our program. So now, as Eric mentioned, the next steps is, now that we have the evidence to give to the pediatricians and the physicians, is now moving that into the clinical world as a formal prescription program. So Lourdes is going to talk a little bit about that next. Thank you.
So good morning, and it's really exciting to be here. I've been working with Eric and Sarah now for almost 2 years, and you know, I've met such great people through this, and it's a wonderful opportunity for us to get out of the office and actually speak to people who can make a difference in other parts of the community. So I really like to think of this project and this whole experience as where pediatrics is going. I've been a pediatrician for 20 years now, and I've really learned early on that you can't really practice pediatrics in 4 walls in a clinic. There's so much that goes on in the life of a child beyond what you can do in an office, and it's only through partnerships that you really keep kids well and healthy. And this is a really true partnership. It was really exciting for us as part of the faculty group to get to partner with public health and to partner with parks on really trying to address a problem that we're encountering every day in our practice, which is childhood obesity, and to do it in a way that's evidence-based, that's accessible, and that feels safe and right for our families is just an added bonus. So we're very excited. We're addressing a gap that we feel is sorely needed in our practice. Who we are, just in case you all don't know, I know a lot of you who work with us already. UHealth Pediatrics is set in 2 clinical settings. One is on our own campus in the PAC building, the other is in Kendall. There's a total of 10 faculty who are general pediatricians staffing those offices, along with ancillary staff, nurses, NAs, some of you guys who come in and do our support groups. And what we do is basically see kids every day. There's about 75 kids a day we see on average. We're there 6 days a week. We see babies as young as 2 and 3 days of life, and we see up to 21 and 23-year-olds. Most of our patients are coming from a diverse group of people, just like our community. About 40% are federally funded or some type of Medicaid plan. We have about 60% that are part of minority groups, and of those, we would say, like Sarah mentioned, about half are obese. And so we knew that there was a need in our patient population to address a problem that was growing. And what we were finding, and this is sort of what our clinical setting looks like, is that we were spending more and more of our time every day talking about things related to nutrition, healthy eating, exercise, screen time. I mean, these were the concerns parents were bringing us. Yes, we were treating colds and strep throats and things like that, but a lot of our well care was being spent, the majority of our well care was being spent on issues related to weight control, exercise. How do we keep our kids from gaining weight? How do we keep our kids who are already heavy and trying to lose weight? How do we help them? My first passion, and my continued passion, is breastfeeding education and breastfeeding support. And one of the first things I learned from lactation groups is that it's great to tell people what they need to do, but if you can't show them what to do, you really fall short. And it's wonderful to give a message, but to give a message without a means, you kind of do a disservice to your patient. And we were really frustrated because we just did not have anywhere to send our families. A lot of our families are low income, they have two working parents, they're busy. I mean, they don't have time to take the child to a ballet class after work or run them over to Taekwondo or the means to pay for that. And so we just didn't have a lot to offer these families that we knew would be beneficial to them. And so when Sarah approached us and Eric approached us about, we're thinking of starting this prescription plan, we were just, over the moon about it, because we thought finally, this was something that was all inclusive, we could offer it to all our families, and it was accessible to them. So being that now all pediatricians are in electronic medical records, it was actually a bonus to us, because we were able to use that as part of how we were going to start referring our families. I should say that as any good collaboration and partnership, one of the exciting things about this project is that we really did all sit at the table. And by all, I mean my nurses, my staff, our residents who are in our clinic, our med students. We actually all talked about what worked, how it would work best, what were the barriers that we would find as clinicians to institute this program, and how would we also benefit from it. And so I thought that was really, really important from the get-go, because it really gave us a joint mission, and all our staff felt that they were involved in supporting this project. So basically, just to walk you quickly through it, the Parks Prescription Program, which is where we are now and what we're doing now, it's part of the pilot, is enrolling families who we are finding at risk. And that can mean a lot of things. That could mean they're already obese, they're trending towards obesity, they have family or parents who are obese and we're concerned about, they're very inactive. So whatever we deem sort of an at-risk child, we basically are writing a prescription and referring. And the way I like to think about this is I'm using the parks as a consultant. Just like I would refer to a cardiologist or a pulmonologist, I'm now referring to this group because I'm writing them a prescription that's being electronically sent. So in my office with my computer, right in front of the patient, I go onto their web landing page, I put in the patient information, the family's with me, they're giving me that information. They're also seeing the importance of it, right? This is real time. I'm sending you right now. This is a decision we both talked about. I know we've done this. We've made the connection, right? So I can't just give them a number and expect them to follow up. I'm assisting them in the process. We go through the registration form. It gets emailed to Parks. Parks, in their wonderful staffing, will now respond to that. They will get the information from the patient, and they will actually generate an email back to us, the referring physicians, as well as to the family to say this has been contacted, and take over from there. They'll help the family with the closest park. They'll try to establish transportation if it's feasible. They'll try to make that first connection to get them into the park that's going to start their program. The great thing about it, and what everybody around the country has really, really liked, is the fact that this all gets reported back to me. And so I know that the family has started the program, and I know how many times they've gone. I also will see that family back, because as part of any child that I'm concerned about with obesity, I usually follow them up about every 3 to 4 months, and that's kind of standard for us. So when we come back in 3 months and are in the room again, I can actually say, hey, great job. You've been to Parks a few times. I see that things are going really well. How's it going? And I reinforce that whole process again, and get the reports from Sarah and Eric and know what's going on. And likewise, can report back to them, right? So hey, I'm concerned about Tommy. He seems like he's going the wrong direction. Can we just get a coach to work a little bit more with him or whatever? And so it's that feedback loop that has made the biggest difference, I think, and which has brought us a little bit more credibility, because it really is a partnership. If I just wrote the prescription and never followed up, I kind of really wouldn't know if it worked, if my patient was happy, if I was doing right by them. And so it's by closing the loop that we've actually, I think, had the most success. And that was really important for us. So I know our time is short, but these are the things that make it sustainable to the physician. So as a physician in the community, if I want this model to be replicated, I need this to happen. There needs to be a liaison or someone in the office who's the champion, who's gonna, talk about glitches. Eric, there's something on the form that's not working. Or, we're not getting a good response rate. Like I told them this morning, I didn't get an email back for a patient I sent yesterday. So there needs to be constant revision of what's going on. The health and wellness specialists were huge to us as physicians. We needed to know that in those parks, there were trained specialists that really, really knew what they were doing about exercise and nutrition. Because we don't want to refer somebody to someone who may be not giving them accurate or current information. The immediate response I talked about, and lastly, we really need to know that we were getting results and we were getting feedback. How we chose our family, essentially early on in the pilot, was based purely on diagnosis by zip code. Endocrine helped us with that, where were our most obese diagnoses coming from, and then parks were picked from those areas, and that's how data has been driven in terms of tracking the zip codes. And lastly, because we were short on time, to me this was really exciting because, like I said, it took us out of our office and it gave our patients another resource. Where I really would love to see this going is as this becomes part of training, and we've already started to incorporate that a little bit. I would love to see a curriculum develop in medical education in terms of med students and residents, where they are actually, part of their requirement is to go out in the field and learn these things. Because I guarantee you that most pediatricians in training right now aren't entirely comfortable with what happens around nutrition and exercise in a child's life. And I know that's amazing to believe, but we just don't get that training. And so if we're able to do this as a model also for medical education, I think we can actually take it into the next step and really make it totally accessible to communities out there where they will reach families in a different way. So that was my brief little statement. And I don't know if we're taking any